So, good evening, all respected Sakina Madam, additional DHS and State TB officer, then OBs and members from all the member associations, Dr. Arshad Sir, the director in charge of State TB Demonstration Center, and Dr. Shias, Dr. Krishna, Dr. Chitra, then Dr. Aparna and the WHO team, then Vice Chairman of this coalition, Dr. Srijit, and patron from the IMA side, Dr. Shamim, then Salima, the convener, and all my dear friends. On behalf of this coalition of professional medical associations for TB elimination, Kerala, I warmly welcome all of you to today's webinar on this very important topic, that is tuberculosis preventive treatment in adults as well as in children. So we all know that tuberculosis preventive treatment is very important in the elimination. When we think of elimination of TB, the treatment, identification and treatment of this TB infection is very important. And the concept of this TB infection is not very unfamiliar to the doctors in Kerala, because Kerala was one of the first states in the country to initiate this TB preventive therapy back in 2020. The terminology may vary. Some still call it as latent TB. Other bodies like CDC still call it as inactive TB. So whatever be the terminology, the concept remains same, and our aim is to take this knowledge to the grassroots levels, because still there are healthcare workers in Kerala or even doctors who are not aware of this identification or treatment of this latent TB, or what we call TB infection. So today we have two eminent faculty to enlighten us regarding this topic. Both of them need no introduction to the medical fraternity of Kerala, because they are very famous. One is Dr. Sanjeev Nair sir, who is a professor in Department of Respiratory Medicine in Government Medical College Trivandrum. He is also the president of APCCM 2025, and is also a national level expert contributing to multiple TB task forces in the state as well as in the national level. He will be sharing us regarding the adult perspective of the TB preventive treatment. And our own Dr. Lalitha Kailas madam, she is also can be called as a teacher of teachers. She is mentored generations of pediatricians in the state. Now she, after retiring from the Government Medical College Trivandrum, she is now the Associate Dean and Professor Emeritus of Pediatrics at Sree Gokulam Medical College Trivandrum. She will be covering the topic of pediatric preventive TB treatment. So before going to the session, I invite Sakina Madam, additional DHS and State TB officer, for giving an introduction regarding this topic. Over to you, Madam.
Okay, good evening all. Very happy to see and hear from Dr. Kailas Madam, Lalitha Kailas Madam and Sanjeev Sir. And this is a very important gathering. I think as I am traveling, I express my sincere gratitude for joining this. All eminent leadership members all are joined in this meeting, and we have members from all the sectors like private sector, public sector, and medical practitioners from the field. And this is a important gathering as far as the TB elimination program is concerned. Just for the introduction, I'm telling some factors like, as per the we are having the STD goals in our for the reference, like we have to reduce TB incidence 80% reduction when compared to 2015 data. That is during 2015 we had 112 cases, like 134 TB cases per lakh population, and we have our TB deaths like 19 per lakh population. So we have to reduce 80% of incidence and 90% of death compared to 2015. And now from our state of Kerala, we are focusing mainly on the TB Mukta Panchayat. So individually, each panchayat, we are giving opportunity to attain the target, like they have to achieve and sustain the TB-free panchayat status. And for this, there are certain criteria, and we are measuring these criteria and giving them the TB-free status. So the testing, the indicators we have taken are the total number of TB examination or presumptive TB examination should be for a population of 1,000. We have to get 30 or more than 30 testing per 1,000 population of the panchayat per year. And also TB notification rate less than 1 cases per 1,000 population in that year. And treatment success rate should be more than 85%. And then the drug susceptibility test rate at least 60%. That for these we have to do minimum, that is out of 100 TB patients diagnosed in that year, at least one must have valid test result for rifampicin resistant through NAT, that is nucleic acid amplification test. The remaining 40% will be clinically diagnosed. So all should be microscopically confirmed, should have NAT result. So the fifth criteria is Nikshay Poshan Yojana. That also I am requesting all doctors gathered here to join in the Nikshay Poshan Yojana as Nikshay Mitras, that we with those patients who had given consent should be given food kit. So some doctors and some volunteers and all members from the community, they are now they are giving support to the program as Nikshay Mitras. And through the government, we are giving 1,000 rupees per month for the treatment of every patient. That is 6,000 per patient for the treatment period as on a monthly basis. This is the nutshell. And regarding the elimination of TB, we have to detect all infected TB cases in the community. So we are finding out all the infected cases. For example, screening of all contacts and close contacts of the confirmed cases through the presented through this ITB examination and also IGRA test that we have discussed earlier. So for giving TB preventive therapy for the infected or positive cases of these tests. So we have to find out all the TB infected cases, who will be the future TB cases when there is a gap in their immunity or reduction in the immunity status of that individual. So we have to find out the TB infected individual from the community and give TB preventive therapy along with timely detection of cases and prompt treatment. So this all I am requesting all of you to give maximum support to eliminate our panchayat, municipalities and corporation areas and the whole Kerala as TB Mukt. So I think this is my brief introduction. Thank you. Thank you all once again.
Sir is not responding, so we will directly go to the talk. I invite Sanjeev sir for the presentation.
Thank you, Dr. Praveen. Thank the coalition, particularly Dr. Praveen and Dr. Shamim and the entire team, and the state TB officer and state TB cell for this opportunity to interact with all of you. Let me start by sharing my screen. I hope it's visible and...
Yes, I will visible and audible.
Yeah, thank you. So I am here today in two capacities. One as the chair of the state, it was then called the Latent TB Working Committee, and also representing the organization of Pulmonologists of Kerala, the APCCM. I finished my term this weekend, and from next week onwards, we'll have a new president for APCCM. So I'm sure that the activity of the coalition will continue with the new president cooperating with the organization. Sorry. Okay, so basically, I am looking forward eagerly to listen to Dr. Lalitha Kailas, who's my teacher, and I've been allocated 20 minutes. So in the 20 minutes that I have, I'm keeping a track of time as well. So in the 20 minutes that I have, I will briefly speak on the situation, the latent TB infection, bit of the epidemiology in India and in Kerala, so that we have a perspective of what is actually there. Also discuss a bit on why we need to manage this latent TB infection. So the state TB officer was just telling us many things that we are doing for treating TB, diagnosing TB, taking care of TB patients. But then this is something relatively new with respect to TB management. It's already there in many other countries in the world, but in India it's something new. And then how we diagnose and how we treat in a few slides. Then we'll move on to the pediatrics part. If needed, towards the end of it, I can come back with further. So the whole idea is based on the fact that infectious TB patients, which include people with cavities in the lung or who bring out acid-fast bacilli in their sputum, they infect other people. And once the mycobacteria inhaled, when they come through aerosols, they go into the lung and they first dealt by the macrophages, which are generally initially they are naive, and you have something called the innate immunity, where the macrophages and the cells, immune cells, cannot actually take care of the bacteria. After some time, you develop something called adaptive immunity, where the cells become sensitized, the T lymphocytes come in, and the bacteria can be managed better now. And then finally, you have the classic pathology of tuberculosis, the cavity form. Once, the granuloma forming, and once the granuloma is formed, then there are three fates for the granuloma. In some people, the granuloma can get calcified and heal altogether, whereas in other people, the granuloma can actually persist as such, with the bacteria also remaining as such and the granuloma also remaining as such. In a very small proportion of people, the granuloma cannot contain the bacteria and the patient immediately develops the disease. Whereas in a significant number of people, the bigger chunk of people, it is the granuloma which remains as such with bacteria inside, where the bacteria come out later when the body's immunity comes down due to some reason. Now, what proportion goes into each of these is estimated, but not very clear. Even the calcified granuloma, one is not sure whether the bacteria actually dead inside that. So anyway, that's the long and short of it. So you can have two conditions in TB. One is called infection and the other one is called disease. We generally call it disease when the patient has signs and symptoms of the condition. So this was just to highlight how fast science is moving. So this is a new edition of the textbook by Dr. S.K. Jindal, who was the HOD at PGI Chandigarh previously. His textbook is very popular. And in that, he had invited me to write a chapter on the natural history of tuberculosis. And immediately after I had written this chapter and the book came out, this whole thing became obsolete. So, that's how fast science is moving. So I feel a bit silly because by the time this book comes out, what I've written in the chapter is no longer the current science. So this was the old science that we actually dealt with, where we actually talked of a uninfected or unexposed individual. Such a person would actually, once they are exposed to the TB bacteria, they develop something called TB infection. The terminology, as Dr. Praveen was telling us earlier, is a bit confusing. So I started with saying TB infection when we formed our committee for the first time. My friends from WHO side corrected me and said that I should use the term latent TB infection, LTBI. After some time, WHO itself changed its definition and went back to TB infection. So we are going back and forth and we really don't know what to call it. The idea why WHO had to go back is that in English, latent means it is something, quiet or something. So not everybody is having latent infection inside. The infection may actually be progressing. So it's just English and the meanings that come in English. Anyway, some of these people with latent TB infection, generally it is believed that around 10% of people with latent TB infection or TB infection develop TB disease somewhere in their lifetime. And the risk is highest in the first year of infection, when about 5% of people actually develop disease, and the remaining whole lifetime, if you follow, it's about 5 to 10% of people actually develop the disease. Now, this was the traditional concept with which we were, as teachers, we were teaching our students until about 2-3 years back. Now, at that point, I would emphasize, if I was taking a class for MBBS students, I would emphasize that you have to differentiate between TB infection and TB disease. So active TB or TB disease, very important, because infection doesn't spread to others. Infection patient has no symptoms. When you do the test for TB, which include X-ray, smear microscopy or a NAT or histopathology, radiology and all that, these tests will come as negative in such people. However, the test for infection, which include the IGRA, tubercular skin test or the CYTB, which we are using now, would come as positive. So that is infection for you. Whereas active TB, the patient would have symptoms. Now that is being challenged now, because it was found that about 50% of TB patients with disease do not have symptoms, but generally they may have symptoms. And when you investigate for disease using X-ray or smear microscopy or a CT scan or ultrasound or histopathology, some of these tests will come as positive. Here, you should not do the test for infection because it could be misleading. So that is a concept that was the traditional concept. Now that has all changed, and now the world talks of, uninfected people, people with eliminated TB infection where the bacteria are already dead, even though they've gone in. It's not clear how you would actually diagnose that. Then you have something called latent TB infection, where the bacteria are there inside the body. The tests are positive for infection, but the bacteria are not multiplying. And then you have something called incipient TB infection, where again the patient is infected and the bacteria are slowly multiplying, but they are not reached the numbers which can actually cause disease. And then you have something called subclinical TB disease, where the patient is totally asymptomatic. Outwardly, he does not have any disease, but if you take an X-ray or CT scan and all, you can actually find lesions. And then you investigate, maybe like a bronchoscopy or something is done, it comes as NAT positive. So those are subclinical TB disease. And finally, you have active TB disease, where the patient has he has florid symptoms, smear is positive, X-ray, everything shows a lesion. So now we have all these, spectrum, and the spectrum probably can increase also. The world is moving towards developing various tests to find out whether the patient has an incipient TB infection or a latent TB infection, which has a lot of importance because then you know whom to treat and who doesn't really need any kind of treatment. Anyway, that is far away. The world is working towards it. The research community is working towards it. But currently, this is what we actually have. What is the burden? So at the global level, you can see that there are other countries in the world which have a higher burden of infection per lakh population, or as a percentage of their population in the world. So you can see certain countries in Africa, certain countries in the Southeast Asia, including Indonesia, Philippines, and all that. Whereas India, the percentage of people who are infected is lower than what we had at the first and only survey done in India was a national sample survey, which was done more than 50 years back. So after that, now we have some reports, which I'll show you, but then it is believed that it's around 30 to 40%, somewhere around 30%. But then because the population of India is so huge, the number of people who are infected with TB infected population in India is more than the population of any other country in the world except for China. So it is more than the population of USA, it's more than the population of Russia, which are the other two big populous countries after India and China. So that is a huge burden of infection that we have in India. And it is because of this huge burden that we thought that we cannot manage TB infection in India. Because how do you manage 400 million people? That is 40 crore people. We don't have the test for it. We don't have the drug for this. So because of that, we thought this is an area which we should not go into because we cannot do justice. But then that is changing. Now, in the recent past, one of the major advances in India has been the National TB Prevalence Survey, which came out. And in this study, as you can see, about 32% of the Indian population was found to be infected. Now, the study was not designed to look at infection, the proportion of infection. It was actually designed to look at the prevalence of disease, or rather pulmonary disease. But then this was also done, the sampling was not very pakka, but still they found that about 32% of the Indian population is infected, which is lesser than the 40% that we were talking about earlier. In Kerala, Dr. Aparna had done her PG thesis in a very good way in Trivandrum district. And in Trivandrum district, Dr. Aparna found that around 20% of the adult population is infected. Mind you, both these percentages that I'm saying pertains to the adult population. So when Lalitha Kailas madam speaks on children, the proportion who are infected is much lower. So it is not to the tune of 20%. We have had studies in the south of India and India long back by Dr. V.K. Chadda. And in those studies in Kerala and all, the proportion infected was somewhere around 4-5%. It might be even lower now. So we have not really done such studies in children anymore in Kerala. So we don't know what is the current proportion of children in Kerala who are infected. Now, in the good old days, when we were running the revised National TB Control Program, or the RNTCP, so that was the control program, TB control program. And in any control program, what you try to do is you try to break this cycle of transmission. So generally, what happens in a community where there is no treatment, no program happening, is that one infectious patient would infect about 15 to 20 people in his lifetime of infectivity. So that 20 people in the population would be infected. Like I told you earlier, 10% of these would break down to disease sometime in the lifetime. That is 2 cases. And out of 2 cases, one would be infectious and one would be non-infectious. So this cycle would continue in the community uninterrupted. In control programs, what you're trying to do is you're trying to make this one man non-infectious as early as possible by early detection and proper treatment of patients. So by doing that, you will prevent the 20 people getting infected, and then you will reduce slowly the proportion of patients infected in the community. There's a long-term plan, So TB control, you talk of reducing TB in the community by 50 years, 100 years and all. You don't talk in terms of 5 years, 10 years and all that. So it is a long journey and you have to keep doing it for a long time. Then now that we have moved to something called TB elimination, now what we are trying to do is among these infected people, you're trying to pick up those people who are at the highest risk of developing disease. So you start managing the infected people, and by doing that, you prevent the emergence of new cases also. So this is what we are trying to do by managing TB infection. So the revised National TB Control Program, which was a control program, has now moved to the National TB Elimination Program, where you're trying to eliminate TB. Now, what does eliminate actually mean? So it's a new NTB strategy where you're trying to, as the state TB officer just told us, we are trying to reduce the death by 95%, by infection by 90%, and zero catastrophic cost. So remember that to reduce infection is the most difficult of all these 3 targets theoretically. And for that, you have to do so many things which we were not doing like 10 years back. So if you look at the modeling exercise done by WHO, if you continue doing what we were doing like 5-10 years back, you will reduce TB. Still, TB would reduce, mind you. TB is anyway on the reduction, going down, but you will reduce only by 1.5% per year. So at the end of the target year of 2035, you would have reduced TB only by 20-25% the incidence. You want to reduce by 90%, but you would reach only 20-25%. So what you really need is to have other things which include TB, managing TB infection in special groups. Only then you can actually reduce TB to the 90% that you want to. The government of India also, when they made the national strategic plan, they also actually did some modeling exercises, and they found that unless and until we manage TB infection or latent TB infection, you will not achieve the targets in India. So it's based on this that we move towards managing TB infection. Now, when we talk of managing TB infection, what generally comes to mind is, immediately people ask you, is it possible? So if you come to the Pulmonology National Conference, we have debates on this topic, and then people come and say that, you can't treat patients properly. You can't treat people with disease properly. You don't have the kits for diagnosis. You don't have the drugs for treatment. How are you going to manage 400 million people? So, it seems a very logical question. So if you look at it, can you manage all the infected people in India or even in Kerala? The answer is a big no. It is not possible to manage all the infected people. So, you have about 400 million or 40 crore infected people in India, and you have almost like 50 to 60 lakh infected people in Kerala, which means that, it's so huge a number. So if you really want to detect and treat all the TB infected people in Kerala, you will have to, screen all the 3.4 crore people in Kerala, and then, successfully detect all the 50-60 lakh people who are infected and treat 50-60 lakh people, which is probably beyond the ability of any of us, even with all the efforts that you put in. So that is not possible. What is possible is that you can prioritize whom to screen, whom to test, and whom to treat. So that can be done, and that becomes feasible. So there, in that context, you look at where TB cases. This is an old study from the National TB Institute, which looked at people who are recently infected and reinfected, as compared to people who are. So about 40% of the population was infected in Bangalore when they did the study. But among those people, only around 1.9% were recently infected, or 1.3 recently reinfected. So only around 3.2% of the population actually had a recent infection. But when you look at the development of TB, you will see that majority of cases develop from people who are recently infected. So that is the context in which we are looking at people who had a recent infection or reinfection with TB. And for that, the best group for us is contacts of TB patients. So that then the focus came to the contacts of TB patients. Not just that, the world has also modeled looking at what are the factors which cause progression of TB infection to disease. So you have HIV infection, you have malnutrition, which are major factors, diabetes, alcohol, active smoking, and all that. Now, the point here is that if you look at it, HIV infection, for example, so you don't even have to do TB preventive therapy. If you manage all your HIV patients very well with antiretroviral drugs and increase their immunity, the breakdown to TB will come down very fast. So you will see that the maximum progress has been made in countries like South Africa because they managed HIV very well. Malnutrition, we had a very good study from India called the ration study, which was studied in a couple of states in the north of India by ICMR. What they did is they gave rations, good food and nutrition to the family members of TB patients. So we do give kits to TB patients, as the state TB officer told us. But then that group will actually increase the treatment success of that TB patient. But then in the what we actually to reduce TB new cases, what you need to do is to give good food to the family members and other contacts of the TB patient. And when they did that, they could significantly bring down TB in those communities. But if you look at things like diabetes, the risk of progression individually is only around 3 times. Alcohol is also around 3 times. Active smoking also 2 times. On the community level, it's very important. But these factors 3 times and all, it doesn't justify the need to actually treat people with TB infection when they have, TB people with diabetes who are infected because of the risk versus benefit ratio. So I'll not go too deep into that because I'm running out of time. Rakesh and his team have done a similar analysis for Kerala, and they have also found that similar risk factors are present in Kerala as well, including undernutrition, which is the most important risk factor for Kerala as well. So in Kerala, if you can feed and properly nourish people who are at risk of developing TB, that is one of the best ways of reducing TB occurring, in addition to the TB preventive therapy. So with all this basis, we, as Dr. Praveen mentioned in the beginning, we were the first state in India to actually launch the services for TB infection management. This we did at a time when the national government had not even brought out guidelines. So Kerala made its own guidelines with this committee, which includes me and Lalitha madam. So we did make the guidelines. So it happens that some of our recommendations are different from the current national recommendation because we did it ahead of them. So these two groups, people living with HIV and children, were already covered. So we didn't have to make any guidelines for that group. So this was already there in the past. Only difference is that children less than 6 years were being given INH preventive therapy. But when we actually moved to the adolescent group also, which was the first group we addressed, IAP was a main leader in that exercise. So when we did that, then the two groups, children less than 5 and children 5 to 15, both the groups, we started a new regime of INH rifampicin for 3 months. Then we moved forward to the next group, which is household contacts, people who undergo solid organ transplant, like a renal transplant or something like that, people with silicosis, immunosuppressant therapy, children with hematological malignancy or lymphoma undergoing chemotherapy. So this is not the end of it. We have plans that in the future we will move to household contacts of all pulmonary TB or even all TB later. You will go to healthcare workers with vulnerability and then all healthcare workers. So all these things are in the plan. So our TB preventive therapy management has to mature and we should have enough resources to keep moving to these groups. As of now, for example, in the national guidelines, healthcare workers are included for screening and treatment, but we really are not doing it in Kerala. So some of the groups like hemodialysis, our nephrologist colleagues, Dr. Noble was part of our committee. He went back to the nephrologist. They discussed and found that end-stage renal disease and dialysis, the occurrence of TB is quite low in Kerala. So they felt that with all the dialysis and everything happening, they could not justify starting TB preventive therapy in such people and complicate the scenario there. So some of the groups which are there in the national guideline, we have not included in our guideline. Now, how do you suppose you're suspected that this person should be screened? How do you do it? So there are 3 tests. The traditional 2 tests are the interferon gamma release assay. The quantiferon gold in tube is the test that we use in Kerala, particularly because the other test, tuberculin skin test and purified protein derivative, the standardized one has not been available in India for the last 20-25 years. When I say that, you should understand that even though this is not available in India, you can actually write Manto and send, and the patient will come back to you with something put in. So that antigen comes from a agency called Span Pharmaceutical in Mehsana, Gujarat, and that is not standardized. So it can give you very wrong results. So because of that, Kerala decided that we will not go with a non-standardized thing. We'll go with the IGRA. That means the Kerala had to spend a lot of money. So many states wanted to do that, but their burden was so high. Kerala has the advantage that, if you saw the National TB Rural Study report, our number of cases are 1/5 of what, UP or something has, and our family sizes are smaller, so that the contacts and others who need to be screened are also lower. So our demand is much lower. So the cost is lower for Kerala, whereas if you did this in UP and all, then the cost would have. So we decided that we will go with IGRA. In the meantime, we were anticipating the arrival of the CYTB, which is a new antigen which would replace and which has replaced Mando, which has very specific antigens. So the ESAT6 and the CFP10. So these are very specific antigens, same antigens which are used in the IGRA test. So this is a skin test exactly like your Mando. So you have to do the intradermal testing, raise a wheel of 5 mm and then read it after 48 to 72 hours. The cutoff of 5 mm is considered positive. So everything like Mando. The only difference is that it is a new antigen, very specific, so that the false positives you get due to, say, BCG immunization or maybe other NTM infections and all will not come with your, or would be less with your CYTB. So now state is slowly moving towards CYTB. Our major issue is that this antigen is not yet, endorsed by the Drug Control General of India for children. So that permission has to come. Pediatricians in Kerala have raised this issue and have gone to the national level and also raised the issue. But the government machinery is slow to. In principle, everybody agrees that this can be done for children. We have validated the CYTB in the adult population and the child population. And in the validation study, the maximum number of subjects were from Kerala. So that the validation is almost like a Kerala validation. So the antigen is very good. It's only that we have to get the license to use it in children. When I say that, we should also remember that many of the pediatricians are eagerly waiting for the CYTB to come so that they can use it for the diagnosis of TB disease. Please remember that these antigens, all three of them, cannot be used for the diagnosis of TB disease. It will be extremely misleading. The current IAP consensus for the diagnosis of TB in children, the TB disease in children, do not include Manto or any of these things. So this is for TB infection, and you should understand that a huge proportion of the people in Kerala, India, are infected. Once you have diagnosed TB infection, you have various regimes available. So the regimes which currently is used in adults, the preferred regime is the 3HP regime, which is INH and rifampicin, which you give once a week for 3 months, which is about 12 doses. Now, you also have a 1 month INH rifampicin regime, which is daily INH rifampicin, which you need to give only for 1 month, which is used mainly in the HIV positive group. Now, this 3 INH rifampicin, where you give INH and rifampicin, you should remember that P is rifampicin, a different rifamycin, the same group, but different drugs. Whereas 3HR is INH and rifampicin, our traditional drugs, and that you give daily for 3 months. This was the regime that the Indian Association of Pediatrics chose for children in Kerala. And this regime is given only in Kerala. So, the plans are there to expand to 6 other states, because for the government of India, when they looked at this, is very attractive because this worked very well in Kerala. It is much cheaper than buying rifampicin, and people are more comfortable with drugs that you are regularly using. So this regime is a Kerala only regime. It is not there in the national guidance. Then you have 6 months of INH. So certain groups, like if you want to give rifampicin or rifampicin, for example, a renal transplant patient. So, if the patient is on sirolimus, you cannot, because of drug interaction, you cannot give rifampicin to such patients. So if there are certain patients in whom you cannot give rifampicin, you can give 6 months of daily isoniazid. And then if the patient has the index case, the person who infected the person whom you're going to treat has INH resistance alone without rifampicin resistance, then you can give 4 months of rifampicin alone. And if the patient's contact or the index case has a MDR TB, you can give 6 months of daily levofloxacin. So these are the regimes which are available. WHO has got a few more regimes which we are not really implemented in India. Our only issue is that, initially we had good completion rates, but off late we are seeing that patients who have stopped treatment in between and then having breakdown and coming back. In some districts, the uptake of these both testing and treatment has been low. So how do we approach? So the first point is you have to identify those eligible for TPT. For us, Basically, it is contacts mainly, and then you have the special risk groups and the HIV positive. So the main three groups. Then you evaluate such people to rule out active TB disease. Very important, rule out disease, because if the patient has disease and you wrongly diagnose as infection, and then you give INH and rifampicin alone, or if you give INH and rifampicin in only 12 doses, the person can develop drug resistance. Whereas if the patient is not having disease, there are multiple studies in the world which show that these regimes do not lead to the development of drug resistance. Now, the third step is test. If they have no disease, you will test for TB infection. That you do currently in Kerala in adults using CYTB and in children using the IGRA. So you do either of these tests, but the testing, mind you, is not needed for children less than 5 years and in HIV positive people. There you just treat them. And then finally, once you have found they are infected in those groups who are actually infected, then you actually start the regime as we discussed earlier. So this is the algorithm on the WHO website. So HIV positive, there is, you look at TB symptoms, the 4 symptom screening, which may be actually increased by India to a 10 symptom screening later. Anyway, the 4 symptom screening, and if they have symptoms, you evaluate for TB disease. If they have no symptoms, and you look at whether there is any contraindication of TPT, if there are no contraindication, you start the regime. On the other hand, household contacts, you look at the age of the household contact. If it's a small child, maybe 3-year or 2-year-old child, then there is no testing involved. Once you're ruled out active disease, I mean, you just go to TPT again. But if the child is more than 5 years, or if it is an adult, you will test in Kerala using a CYTB now, or in children using a IGRA. And if that is positive, you will actually again rule out TB if needed, if you're not done that earlier with the X-ray and all that. And then you again give the TBT. So this is how you actually go. The other high-risk groups also, you have to test. If positive, you will treat. So this is in brief how you actually go with it. So I'm sorry, I exceeded time by around 5 minutes. So now we are understanding TB infection better, but there is still a lot more to understand. We should understand that the burden of infection is extremely high, 32% of the Indian population, 20% of the Kerala adult population. And if you don't address TB infection, at least in those special groups who need to be addressed, we will not eliminate TB. So it's very essential for us. Diagnosis and treatment, these tests are very costly. For example, IGRA, if you send to the private sector, is very costly. The drugs are also costly. All of them are available free of cost to the subjects. We can't call them patients because they don't have disease, to the contacts and all that in our program. We need to address those gaps in why many people are not testing, why many people are. Basically, doctors have a big role in people not taking treatment. So I know many doctors telling them there's no need to take, you don't have TB. But then you give TB preventive therapy only when you do not have TB. So that is a principle our doctors, many of them don't understand. And then, you have to prioritize those people who should be tested and treated. I've had major discussions even in this month, on why we are not treating people of who are contacts of extrapulmonary TB, for example. And so many other discussions like that, why we are not treating people who have diabetes and who are TB infected. So that will come in the future, but as of now, we have prioritized who needs to be tested and treated. So thank you for the patient listening, and I'm sure that after Lalitha Madam speaks, we can take questions together. Thank you.
Thank you, sir, for the excellent talk. There will be questions, and we will take it after Madam's talk. Now I invite Lalitha Madam for covering the pediatric aspect of TB infection.
Okay, good evening, everyone. And I think it was really a brilliant lecture by Dr. Sanjeev, elaborating the whole, that is the basis of the TB preventive therapy, mainly from the adult perspective. So I think that has really made my task much easier. But I'm afraid that there is going to be a considerable overlap. And I'll try to cut it short as far as possible, but bear with me. Again, as we'll start with the burden of TB, that is, as Sanjeev said correctly, tuberculosis still remains the leading cause of morbidity and mortality worldwide. And of this, India contributes to roughly 1/4 of the TB burden. In India, the children in the age group of 0 to 14 years, that is roughly 3.42 lakhs children get TB every year. That is contributing roughly 31% of the global burden. But overall, this country, the pediatric tuberculosis constitutes roughly 13%. So this already has been discussed. That is the NTB strategy, where the WHO used to reduce the TB deaths by 90% by 2030 and 95% by 2035, and to reduce the incidence of TB by 80% by 2030 and 90%. And actually, the government of India has projected our target as elimination of the TB by 2025, but as already we are nearing the end of the 2025, but we are far away from this. But still, I think we can do better. So already they had talked of elimination of the TB. There are two critical components of the elimination of the TB. One is break the chain of transmission of the TB by the prompt diagnosis and management of the infectious cases. So management of the infectious cases, thereby we can decrease the transmission of the cases of TB. Second important component is the identification of the latent TB infection and use preventive therapy. So these are the two important components of elimination of the TB. So here comes the TB preventive therapy. That is the topic of the day. This terminology is an umbrella term which includes both the chemoprophylaxis, that means a primary prophylaxis, that is prevention of establishment of the new infection, say for example, as in the case of less than 5 years. And the second component of the PEP is the treatment of LTBI, that is the latent TB. Here we are preventing the progression to disease. So both these terms comes under TB preventive therapy. Now, often I think we have heard Dr. Sanjay using TB infection and disease. Again, I'm reiterating that infection is the newer term for latent tuberculosis, TB infection, whereas tuberculosis disease is the new term for active tuberculosis. Often I think I'll be using these two terminologies interchangeably. So again, you have to understand that not all the TB infected individuals develop disease or they become symptomatic. So they harbor a latent infection and have a lifelong risk of developing the disease. So what happens when you come into contact with a TB case? About 70% will not develop any infection and no disease, whereas 30% will develop infection. And of that, roughly we say that this is what Dr. Sanjay has been telling. The overall risk is about 5 to 10% overall lifetime risk. But see, this risk is to the tune of 50% in children less than 1 year infants. And also roughly around 25% the risk is 1 to 5 years. So by infection means they can go for the primary disease, whereas or else they can go for a persistent latent infection. And that is what we said, they can get later reactivated. So this is natural history of TB exposure of a child or an adult who is exposed to a tuberculosis case. So by definition, what is LTBI or tuberculosis infection? It's a state of immune response to Mycobacterium tuberculosis antigens with no evidence of clinically manifest active TB. This is what Sanjeev has said has become obsolete, but still I think for you to understand clearly, I think this may help you. Latent TB means asymptomatic TB infection, means asymptomatic, but you get test positive and often chest radiograph is abnormal. Whereas TB disease or active TB, often symptomatic, the TST or AGRA is positive, but they cannot be used for diagnosis of TB as already mentioned, and the XRHs may be abnormal. So then they have no signs of TB disease and not infectious. But then why do we need to treat? Because again, I said, there are risks for active disease later and for becoming infectious. So several studies have shown that this has already been quoted by Dr. Sanjeev. About 5 to 10% of those infected will develop into active disease over the course of their lifetime. That is usually within 5 years after the initial infection. So this 5 to 10%. But however, if we implement the TB preventive therapy, the chance of this progression decreases by 90%. So that is the importance of the TB preventive therapy. So just with the implementation of this TB preventive therapy alone, they can result in a decline in the annual TB incidence of 12%, independent of the other background interventions. So definitely a TB preventive therapy will cause a considerable reduction in the number of TB cases every year. So we said there are some factors for the TB disease, the patients developing a TB disease after a tuberculosis infection. So basically the factors are immunological status. Immunological status is immunocompromised, especially even by virtue of their age. That's why I said infants are more prone. Or if the contacts of a bacteriologically confirmed TB patients also, then the risk is more. If there's an HIV co-infection, or if they're on immunosuppressive therapy for any diseases. So all these are the factors, risk factors for a tuberculosis infection getting converted to a TB disease. And especially the children, they are more vulnerable. Especially the children with household contact of TB, the risk of TB infection is higher. It is higher in children. And also the children in contact with the smear positive cases, they are more prone to develop the disease compared to the other contact. So, and also the progression from infection to the disease is more in children, and also the risk of more severe and disseminated infection in children. So all these factors make that the children are more vulnerable to get infection and also for getting that infection to disease. So moving on to the preventive therapy, this is already existing because we know that we pediatricians used to implement or give this TB preventive therapy in all children less than 6 years who are household contacts of pulmonary tuberculosis and all people living with HIV. This is quite familiar to us because as soon as we know that they have a child coming into who had contact with an active pulmonary tuberculosis, we used to start them on INH preventive therapy. So this is nothing new for pediatricians. But now with the latest introduction of the TB preventive therapy, an additional groups of individuals have been considered as eligible for TB preventive therapy. So already said, less than 5 years for household contacts of pulmonary tuberculosis, we continue to give them. Similarly, a baby born to a mother who is diagnosed to have TB in pregnancy, again, after ruling out congenital tuberculosis, we give them TB preventive therapy. This is the existing practices. Now, these are the additional group that is already mentioned, children above 5 years, that is 5 to 50 years, or household contacts of pulmonary TB. After testing, they are also offered TB preventive therapy. Similarly, children and adolescents, that is 12 months to 15 years, living with HIV, they are also offered TPT, but without testing. Less than 2 years children also should be given TB preventive therapy if they have a contact with pulmonary tuberculosis. In addition to that, this group of children are planned to be initiated on a transplant or planned to be initiated on immunosuppressive drugs for a longer duration. Say, for example, like more than 2 milligram per kilogram of steroids for more than 2 weeks, in the case of leukemia or a nephrotic syndrome or systemic inflammatory condition. That is where we plan, I think, and test for latent TB. And also anti-TNF treatment, those who are on dialysis, and also for planning for an organ or hematological transplantation, they are also now considered as eligible for TPT, but after testing. Apart from all these categories, again, children from 5 to 15 years, those who have chronic immunosuppressive conditions, then as decided by the pediatrician, they shall also be tested and treated for LTBA. So this is the table which what I have been telling. Household contact, less than 5-year-old children, no need for testing. But 5 to 15 years after testing for LTBA, we'll offer them preventive therapy. Baby born to a mother with active TB, again, TPT without testing. Similarly, contacts of drug-resistant TB. Whereas children living with HIV, more than 1 year, all are offered TPT, no testing. Less than 12 months, if there is a contact with TB. And post antituberculous treatment also, we are offering TB preventive therapy. These are also, I said, those who are on anti-TNF treatment, on dialysis, or long-term immunosuppressive therapy, or planning. After testing, these groups also require or maybe offer TB preventive therapy. So I have been telling that household contact. What do you mean by household contact or close contact means a person who shared the same environment or same enclosed living space as the index patient for one or more nights or more frequent or extended daytime periods during the 3 months before the start of the current treatment. So this is considered as a household or a close contact who are eligible for TPT. So before starting a TB preventive therapy, it's very, very important to rule out active tuberculosis, because how are we going to do that? You know, from the history and the clinical examination, when do you suspect TB? Like they have a prolonged fever, prolonged cough, or weight loss, etc. The X-ray chest shall be taken to rule out active TB. And if the X-ray chest shows some abnormality, definitely the child will be further evaluated for TB according to the national guidelines like gastric aspirate or sputum, CBNAT, etc., etc. Or if they have a extrapulmonary, then clinical examination of the lymph nodes and a thorough history for all the symptoms for extrapulmonary tuberculosis shall be done. And also we have, that is in Kerala, we have a clinical committee district. A district clinical committee is there to take decision in case of doubtful cases. And I'm also happen to be a member of this clinical committee. No, again, Dr. Sanjeev has mentioned, but I think reiterating, there are two testing methods. One is a CYTB and the second is IGRA. But as of now, CYTB is recommended only for 18 years. This is actually very disheartening for a pediatrician like me, because we have been arguing it out for long for the CYTB to come. And finally, when it has been out, it is not recommended for children. But as Dr. Sanjeev has said, we are exerting pressure on the Central TB Division and the Kerala handout. Soon it will be available for children also, I hope. So, but important again, both these tests measure immune sensitization, that is the type 4 or delayed type 2 sensitivity to the mycobacterial protein antigens that occurs. That means it indicates only a latent infection, not an active disease. It only indicates that the tubercle bacilli has entered into the body. It is not for the diagnosis of a TB disease. So these are the tests. So just few words about IGRA. Here, actually, we test the blood. The blood is stimulated with the mycobacterium specific antigens like ESAT6 and CFP10 that is available as quantiferon gold, ELISpot, TB, etc. Again, I repeat, to detect latent TB infection, they cannot distinguish between a latent TB infection and active TB disease. But the benefit is, when compared to the TB skin test, requires only a single patient visit, and the result is available within 24 hours. And the BCG, though usually we used to say that the PPD, the Mantoux test, gets affected by the prior BCG, which will not happen in the case of IGRA. But the limitation, the sample must be processed, it has to be sent early, and quite expensive. So here comes the newer one, that is a CYTB. It's a new diagnostic skin test. It's a new generation skin test for detection of the TB. It's very easy to use, just like a Mantoux test, and can be used as a simple point of care test in the field. So again, note that it is much more, whereas the PPD is a crude extract of all the mycobacterium TB antigens. This is mainly based on the specific antigens like ESAT6 and CFP10, just like that as of a IGRA. So it's not affected by BCG. One dose is 0.1 ml, and it's actually 1 ml is the whole vial. And 0.1 ml is giving intradermally, and we read it after 48 to 72 hours, and in duration of more than 5 millimeter is considered as positive. So as I said, it was first manufactured at State and Serum Institute, Denmark. Here now it's being manufactured by the Serum Institute, so it's available and a much cheaper. But sad thing is that now it is approved for only 18 years and older. Soon we hope that it will be available for use in children also. Just the basic comparison. Antigen is same for CYTB and IGRA, ESAT6 and CFP10, and specificity is high even in BCG vaccinated. It is not, BCG vaccination will not affect the CYTB test or IGRA. Sensitivity is also high. It is easy, simple test and interpretation in the case of YTB, requires lab, and it is cheap and it's very high in the case of IGRA. And availability, it's because it's indigenously manufactured, can plenty available. But IGRA, we know the availability is always a problem. Sometimes now, for example, now there's a shortage. So in between shortages come. And for 2 visits are required, just like Mando, they have to come after 48 to 72 hours to read the test, whereas for IGRA, we need only a single test. This, I think, is already been mentioned. Now, after discussing this test and all, then what are the regimens for latent TB treatment? Of course, we are familiar with the 6 months of INH therapy. That is what we have been doing. And this is one of the options given by the WHO. And the next is 3 months of INH and rifampicin 3HR. And this is the new one, that is the weekly rifampicin with INH, that is called as a 3HP for older children. But now in Kerala, as Dr. Sanjeev has mentioned, we have taken the preferred regimen in Kerala is 3 months daily dose of INH and rifampicin. As Sanjeev has mentioned, we have started much ahead of all the other states in India roughly in 2021. And mainly we have chosen this INH and rifampicin because we pediatricians are familiar with this INH and rifampicin, and we have FDC, fixed drug combination. We have been using that for treatment because before the introduction of ethambutol, I think this is the combination that we have been using. So absolutely, there is nothing to worry. And also, even if the 3HP comes, it is there only for more than 2 years. So in Kerala, this is the one that has started. And all eligible children and adolescents who were diagnosed with TB are offered 3 months of HR, of course, after ruling out active TB. So why? Again, as I said, there's a low risk of adverse effects compared to the longer duration. For example, if we give INH, then we have to give for 6 months. So naturally, it's a longer duration. There may be a chance of more toxicity. And also because it's only 3 months, the adherence is much more greater. And also, as I said, we pediatricians are much familiar with the use of INH and rifampicin for 3 months. And already we have child-friendly fixed dose combination. And also when we use INH alone, there's more chance of the development of resistance. On the whole, there is considerably more resistance to INH, but there is only resistance to rifampicin is comparatively lower. So we preferred and we chose 3 month 3HR. The dose is slightly high. That is, for 10 years and older, the dose is only 5 milligram per kilogram, whereas less than 10 years, we use a higher dose of INH, that is 10 milligram per kilogram per day. And the rifampicin also less than 15 milligram per kilogram per day, weight band, but older children 10 milligram. So the dose is 10 milligram INH and 15 milligram rifampicin for chest, and we have the FDC, and accordingly we can decide it. So this is if you are using INH alone. Again, more than 10 years, 5 milligram per kilogram, and less than 10 years, 10 mg per kg. And this is not applicable right now because now to HP, 3HP is not being used for children. Another important addition is the pyridoxine. The pyridoxine 10 milligram daily for children and 25 milligram for adults. Then why? Mainly because we're using a high dose in pediatrics, we're using for 10 milligram per kilogram. So naturally the risk of peripheral neuropathy is more. And also, mainly children with TB are more likely to be malnutrition. So malnourished children are more prone to develop peripheral neuropathy. And often this may be undetected in children. So it is better to give pyridoxine. And then another important thing is, so far, last a few years back, we used to say that we don't have any preventive therapy for drug-resistant TB, but now we have even the contacts of drug-resistant TB can be given individualized preventive treatment as per the drug sensitivity of the index case. So if it is a rifampicin monoresistant TB, we have 6 months of INH, and we have INH resistant TB contact, we have 4 months of rifampicin, and we have even now MDR-TB. MDR-TB, I hope you are aware, that is resistant to INH and rifampicin. We can give even levofloxacillin, that has been recommended, that we have been using 6 months of levofloxacillin, roughly to the tune of 15 to 20 milligram per kilogram. So now we have even preventive therapy even for a drug-resistant TB. So before starting that, we have to just do some baseline assessment, that is history of any drug allergy, any comorbidity, and better to test the liver enzyme as the baseline. And then, of course, assessment of the social and financial situation of the family. And also once we start, we ask them for a clinical follow-up and look for any signs and symptoms of TB disease, because we assume that these children do not have any TB disease, and accordingly we are starting. But during the follow-up, just watch them or monitor them for symptoms of TB disease or adverse reactions, and also monitor the adherence, and also see if there is any missed dose. And also outcome, we label that as the 3H are at least 80% of the recommended doses. That is, this is for 3 months, means 12 weeks, 84 doses, at least 80% of this completed as a treatment completion. A person has initiated, but they developed TB disease, then we say treatment is failed. This is all for documentation purposes. And also these children need long-term follow-up, because all individuals have completed this treatment. Also, we have to follow them up every quarter by the primary healthcare physician for 5 years to look for any active symptoms, because we said that the risk is the first 5 years after contact. Are there any contraindications? Yes, if there is an active TB disease, it's an absolute contraindication for TPT. If they're on a hepatotoxic drugs, then also be careful. If there is an acute hepatitis, either an acute or chronic, or if any sign of peripheral neuropathy, you have to be cautious in using INH. So the take-home message is that TB preventive therapy is the key component of the global TB elimination program, and it is offered to the children at high risk of exposure to TB or high risk of progression from infection to disease. Thus, we have listed the group, and the TBI testing is either by CYTB or IGRA. And mind you, the testing is not required in household contacts of pulmonary tuberculosis in less than 5 years of age or children living with HIV. And 3HR, 3 months of INH and rifampicin, is the regimen that is currently used in children. But again, rule out active tuberculosis before you start TPT, and ensure adherence to TPT, and ensure close follow-up for a minimum of 5 years. Yes, if all of us get actively engaged in tracing the contact and testing for TPT and implementing the preventive therapy, definitely we can end tuberculosis. So thank you. Thank you for the patient here.
Thank you, madam, for the excellent presentation. If you have any queries, either you can post in the chat box or you can unmute and ask.
I think there are a few queries there. Praveen, while you read, I need to make a correction. So Dr. Deena Nair is there on this call, and she actually gave me information that the DCGI has actually approved CYTB for children. So I think I had discussed this at national level. So currently, what is the status? Maybe somebody from the state TB cell can actually tell us on the use of CYTB in children. So I think probably I'm not applicable.
Sir, Dr. Shias here. CTD have not given the permission. Maybe we may get.
Yeah, but this letter, Dina, can you tell us something?
Because sir, last week also one meeting was there regarding the TPT implementation. In that also they were mentioning that it is not given permission last week also. Also they were planning to expand the 3HP regimen. Like in very few states this 3HP is given widely. Most of the places it is like 6H regimen is given for the children. So actually they were asking every state to implement the 3HP positively. And earlier the problem with Kerala was, in addition to what Sir said, the problem was the availability of the drugs. Now the the drugs for the 3HP regimen is available in Kerala, not in the dispersible tablet form, but the adult formulation 300 plus 300 INH plus rifampicin 300 plus 300 is available. In addition to that, individual tablets 150 milligram of the rifampicin is also available now in good numbers. So we are planning to give this regimen to pediatric population also. Of course, after the state LTBA committee confirmation. So actually, this is also a new information for me.
Yeah. Deena, would you like to add something to Dr. Deena Nair is
Yeah.
actually doing a research in Malappuram, doing how to actually improve the uptake of TB preventive therapy and to give recommendation. I think that research will give us a lot of findings from Kerala. So, Deena, some point you want to say?
Yeah, thank you, sir. And thank you. I'm privileged to attend this webinar. Actually, DCGI has approved this ITB for use in children more than 1 year. And also ICMR as well as DCGI has approved it. But I think CTD is yet to give an approval for its use in under the programmatic mode. So we were also waiting for that approval from CTD. So we had actually contacted Dr. Urvashi also with in this regard, and she has promised that she will immediately issue an order. So then we can, because there's a long wait for IGRA. Actually, if you see now currently in the program we use only the site TB is given only for more than 18 years. For less than 18 years and more than 5 years, we are using IGRA. And because of the IGRA, the logistics, and it requires more of infrastructure and sample transportation and all. There's a long wait for the IGRA testing. So actually, the whole process of identifying the infected cases are actually delayed. So if CYTB is approved by CTD for use in the program, it will be of great help to the children more than 5 years. Yeah.
Thank you, Deena. Dr. Deena is senior scientist at the National Institute for Research in TB at Chennai. So I think that is valuable information, Deena. And Lalitha madam, Namala side from IAP side, you can push Dr. Virendra Singh.
Yeah.
And from our side, we'll push, the Central TB division. I have already, when last visit to Delhi, I had personally spoken to all these people because you have all been behind me to get it used in children. So I did go and speak to everybody in Delhi. And they actually promised me that there was a meeting coming up in a week's time and they would actually approve it. But I think it's 4 months since then, nothing has happened. So we'll again.
Yeah, I think same thing happened with the IEP, our Kerala State IEP President, Dr. Riaz, through I think Riaz and Praveen and all, I think we had
Riaz also went and met
communicated to Dr. Virendra Singh, and they said, no, there is actually no real hard facts preventing it. But some logistic reasons somehow, but months have been flowing. Hopefully it will be available in soon. We are hoping for the last 2-3 years or more than 3 years, I think.
Madam, ഇത്രയും വരെ എത്തിക്ക് എന്തായാലും ഇനി വലിയ താമസമില്ല, അതെല്ലാം കിട്ടും.
Okay, right. We'll hope.
ഇപ്പൊ സപ്ലൈസ് CYTB ആസച്ച് വലിയൊരു ഇതൊന്നുമില്ല, ഒത്തിരി ഇരിപ്പുണ്ട്, സ്റ്റോക്ക് ഉണ്ട്, ഇനിയും വലിയ പ്രശ്നങ്ങളില്ലാതെ ഇനിയും കിട്ടുമെന്നാണ് പറയുന്നത്. അന്നേരം പിന്നെ നാച്ചുറൽ ആയിട്ടും ബാക്കി അനുമതികളും പെട്ടെന്ന് കിട്ടണം.
But again, as Sanjeev said, I think everyone is waiting mainly to diagnose TB infection. No, that should be the purpose. That should not be the purpose. That is one message that I would like to. It should not be used for the diagnosis of a TB disease. It's only for a latent TB infection, just like a MATO. Okay, shall we go for the questions?
Yeah, we can take a few questions. There are a few questions in the chat box. One is TB preventive treatment indicated for patients requiring long-term steroid treatment?
Yes, definitely. That is one group I have mentioned. For children especially, I think for adults also. If they're requiring steroids for more than 2 weeks, like in the case of a nephrotic syndrome, they're considered as immunosuppressed, they have to be given TB, they have to be tested, and if needed only, tested. Just like previously we used to do a MANTO test before we start steroids.
Then a similar question is in adult, if a person is diagnosed with inflammatory colitis and is planning to start on Mesacol, can we start on DPT?
So I'm not really aware of what is the risk. Madam പറഞ്ഞതിൽ ഞങ്ങൾ ആ ഗൈഡ് ലൈൻ ഉണ്ടാക്കിയപ്പോൾ the first thing I'll clarify is Madam said about we had put in that patients with nephrotic syndrome and children with nephrotic syndrome who are on long-term steroids, you could actually give TB preventive therapy. But generally in adults, long-term steroid, it's not a group which we are actually testing right now. The risk is there. For example, even people on inhalers, which are supposedly safe, there is a higher risk of developing TB disease, but all those groups we are not covering as of now. Misa, iduvolore question very, I mean, like this question is on Misa call. So generally what we do is we have a look at what is the added risk for TB when certain products like this are given, anti-inflammatory products are given. Looking at the increased risk, we take a decision. Generally, as of now, it is recommended for people who get biologicals like anti-TNF drugs, where the risk of developing TB is almost 20 times, almost similar to HIV. Whereas other biologicals, the same amount of risk is not there. But practically what we do is if a rheumatologist or if a gastroenterologist say that this patient is at higher risk of TB, I want to test for TB infection, or they might have already got the patient tested and found positive, and they feel that TB preventive therapy is needed, we generally oblige. We don't go into a conflict on.
A similar question is before rituximab initiation, is IGRA alone sufficient? If not, risk for TB.
Means before starting rituximab.
Rituximab is IGRA alone sufficient to roll out, I think, TB infection.
I think definitely we have to see the patient as a whole. The patient is symptomatic or something, then we have to do a little more detailed investigation. Otherwise, I think ICRA and X-ray chest would be enough.
Madam, one more thing to add. Doing a chest X-ray is absolutely essential for before starting TPT to roll out active TB.
Yes.
Just symptomatic screening is not enough.
No, we
Even
have
if
included that in our talk also, that has been included. X-ray chest is a must.
Chest X-ray chest is a must, even for asymptomatic child
right.
and
That's it has been included.
ആദ്യം അത് പറഞ്ഞിട്ടില്ലായിരുന്നു അല്ലേ മാഡം? ഇനിഷ്യലി നമ്മൾ അങ്ങനെ എക്സെപ്റ്റ് ചെയ്യണമെന്ന്
ആദ്യം മുതലേ നമ്മൾ ആദ്യത്തെ തുടങ്ങിയപ്പോൾ തൊട്ടേ ഉണ്ട്. നമ്മൾ ശരിക്കും ടു ബി ഫ്രാങ്ക് വിത്ത് യു, വെൻ വി മേഡ് ദ ഗൈഡ് ലൈൻസ് എക്സ്റേ ആയിരുന്നു WHO പറഞ്ഞിരുന്നത്. We did not stop at X-ray. In fact, Dr. Akhilesh from Amrita, who actually worked on that chapter, he put in a lot of other things also. You palpate for nodes, he even put in ultrasound and things like that. That's practically doable. We did not enforce those things. It's ideal. People do ask, X-ray pulmonary TB rule out, but then what if the patient has a lymph node TB? So all forms of active TB technically should be ruled out. So you should actually palpate for nodes. You should ask for all symptoms of TB. So all those things should be done. Very strict, very stringent effort should be made to rule out active TB, because if the patient has TB disease and then you wrongly give TPT, that will be disaster.
Yeah.
സാർ പറഞ്ഞ പോലെ ഇത് ആദ്യം തൊട്ടേ നമ്മൾ പറയുന്നുണ്ടെങ്കിലും പെരിഫറി വരെ ഈ മെസ്സേജ് എല്ലാ സ്ഥലത്തും ഒരേപോലെ റീച്ച് ചെയ്തിട്ടില്ല. പലരും എക്സ്റേ എടുക്കാതെയൊക്കെ TPT നമ്മൾ കൊടുക്കുന്നതായിട്ട് ചില സ്ഥലങ്ങളിലെങ്കിലും കാണുന്നുണ്ട്. അതുകൊണ്ടൊന്ന് ഒന്നുകൂടെ റീറ്ററേറ്റ് ചെയ്ത് പറഞ്ഞതേ ഉള്ളൂ.
നടക്കാത്ത കാര്യങ്ങൾ ഇംപ്ലിമെന്റ് ചെയ്യണം. ഇല്ലാതെ കൊടുക്കരുത്, മരുന്ന് കൊടുക്കരുത്, എക്സ്റേ ഇല്ലാതെ കൊടുക്കരുത്. TPT ട്രീറ്റ് ചെയ്തില്ലെങ്കിലും കുഴപ്പമില്ല, എക്സ്റേ ഇല്ലാതെ ട്രീറ്റ് ചെയ്യണമാണ് മോർ ഡേഞ്ചറസ്.
അതുപോലെ ഇപ്പൊ പുതിയ ഒരു ചേഞ്ച് വന്നത് ഈ മൈക്രോബയോളജിക്കലി കൺഫേംഡ് TB എന്നുള്ളത് മാറി നമ്മളിപ്പം എല്ലാ പൾമണറി TB എന്നുള്ളതായിട്ടുണ്ട് അല്ലേ സാർ? അങ്ങനെയല്ലേ?
ഷിയാസ് അങ്ങനെ ആക്കിയോ?
ആക്കി. ഓക്കെ, അത് കമ്മ്യൂണിക്കേഷനിലേക്ക് പോയിട്ടുണ്ട്. പിന്നെ അതേപോലെ സാർ ഇപ്പം സംശയങ്ങൾ തീർന്നെങ്കിൽ അടുത്ത നമ്മുടെ ഈ 3HP റെജിമെൻ പീഡിയാട്രിക്സിനൂടെ എക്സ്റ്റെൻഡ് ചെയ്യുന്ന ഒരു പരിപാടി ഇപ്പം ചില പീഡിയാട്രിഷ്യൻസ് ഇൻഡിവിജ്വൽ ആയിട്ട് നമ്മളെ വിളിച്ച് കൊടുക്കാൻ പറ്റുമോ എന്നുള്ള ചോദിക്കുന്നുണ്ട്. അന്നേരം ഒരു ഇൻഡിവിജ്വൽ ലെവലിൽ കോഴിക്കോട് ഭാഗത്തൊക്കെ ഉള്ള പലരും 3HP കൊടുക്കുന്നുണ്ട്. അന്നേരം നമ്മളതൊരു LTBI കമ്മിറ്റി പോലെ കൂടി അതൊന്ന് ഒഫീഷ്യലാക്കി കൊടുത്തായിരുന്നെങ്കിൽ എല്ലാവരും everyone will be happy and safe.
The only thing is that already we are, I think, this is not a uniform. Kerala, we have a separate regime and other state we have. So if you're going to make, but again, only above the age of 2 years, no? Above the age of 2 years, only HP, 3 HP.
Of course.
But less than 2 years, then what is the regimen that you have suggested?
അതിപ്പം നമ്മൾ പ്രസന്റ്ലി ഉള്ള 3HR-ഉം
3HR, okay. But unless you have a disposable tablet and all, will it be easy?
Disposable tablet. We had some very newborn children with who were contacts. അപ്പൊ അവർക്ക് എന്ത് കൊടുക്കും എന്നുള്ളൊരു വലിയ ഡയലമായിരുന്നു. ഐ ഡോണ്ട് നോ, യു മൈറ്റ് ബി ഏബിൾ ടു ആൻസർ ദാറ്റ് ബെറ്റർ. സിറപ്സ് അവൈലബിൾ ആണോ, DTs അവൈലബിൾ ആണോ?
സിറപ്പ് അവൈലബിൾ അല്ല. DTC ഐ തിങ്ക് കുറച്ച് ഹയർ കോൺസെൻട്രേഷനേ ഉള്ളൂ HP എന്നാണ് എൻ്റെ
പക്ഷെ
ഒരു.
വളരെ ന്യൂ ബോൺ
HP നമുക്ക് നിലവിൽ ഡിസ്പെൻസിബിൾ ടാബ്ലറ്റ്സ് അവൈലബിൾ അല്ല.
അല്ല, that is the problem. So I think make it available and then start. Once you start, I think it has to be uniform.
അല്ല ഗിവിംഗ് 3HP ആസ് ആൻ ഓപ്ഷൻ, അത്
Option is
ഒഫീഷ്യലായിട്ട് ചെയ്തിരുന്നെങ്കിൽ ചില ആൾക്കാർക്ക് വൺസ് വീക്ക്ലി കൊടുക്കുന്നതുകൊണ്ട് ഇതാണ് കംഫർട്ടബിൾ. പ്ലസ് CTD നമുക്ക് ഓൾറെഡി പെർമിഷൻ കിട്ടിയതാണ്. ഒന്ന് 2021 വന്നു. ഇപ്പോൾ റീസെൻ്റ് ആയിട്ട് വീണ്ടും ഒരു DO ലെറ്റർ ഇത് കൊടുക്കാം, ഇതാണ് പ്രിഫേർഡ് ചോയ്സ് എന്നുള്ള രീതിയിൽ ഒരു ലെറ്റർ വീണ്ടും വന്നു. അന്നേരം നമ്മുടെ ഭാഗത്തുനിന്നും കൂടെ അത് ഈ പറഞ്ഞ പോലെ അറ്റ്ലീസ്റ്റ് കൊടുക്കാൻ വില്ലിങ് ആയിട്ടുള്ളവർ കൊടുത്തോട്ടെ എന്നുള്ള ഒരു കമ്മ്യൂണിക്കേഷൻ ഫോർമലായിട്ട് പോയാൽ നല്ലതായിരുന്നു.
we'll discuss that in a meeting and see what's happening in the other state. In younger children, what type of 3HP they are giving or they are practicing.
അതെ, നമ്മൾ ഒരു
അതൊന്ന് നോക്കൂ.
പ്രോസ് ആൻഡ് കോൺസ് നോക്കിയിട്ട് തീരുമാനം എടുക്കാം.
ഒരു യൂണിഫോം ആയിട്ട് പോകുന്നതായിരിക്കും ഷിയാസ് നല്ലത്.
Yeah, that's what I
അതിന്
also
ആൾക്കാർക്ക്
think.
ഈ ഒരു പ്രോഗ്രാമിനെ പറ്റി തന്നെ അറിഞ്ഞു വരുന്നതേ ഉള്ളൂ. അപ്പൊ നമ്മളിങ്ങനെ പല റെജീംസ് ഒക്കെ വെച്ച് കൺഫ്യൂഷൻ ഉണ്ടാക്കണമെന്നില്ല.
ഇല്ല, ഇത് മീൻസ് കുറെ പീഡിയാട്രീഷ്യൻസ് തന്നെ ഇങ്ങോട്ട് ആവശ്യപ്പെട്ടതാണിത്. നമ്മൾ ഇത് അത്ര ഒരു ഇതായിട്ട് എടുത്തതല്ല. പിന്നെ
ആദ്യം പീഡിയാട്രീഷ്യൻസ് അവെയർ ആവണം ഇങ്ങനെ ഉണ്ടെന്ന് ഡോക്ടർ സഞ്ജീവ് സർ. ആ ഒരു അവയർനെസ് പെർസെന്റേജ് നമ്മൾ
കൊടുത്തോണ്ടിരിക്കുന്നത്.
ബാക്കി സ്റ്റേറ്റിലെല്ലാം ഓൾറെഡി കൊടുക്കുന്നുണ്ട്. എന്നിട്ട് നമ്മൾ കേരളം മാത്രം ബാക്കിലോട്ട് നിൽക്കേണ്ട കാര്യമില്ല. ഈവൻ ലക്ഷദ്വീപിൽ കൊടുക്കുന്നുണ്ട്.
കേരള നമ്മൾ വളരെ ഫ്രണ്ടിൽ 2021 ഇത് സ്റ്റാർട്ട് ചെയ്തു. That was the reason that we have started. At that time, the HP was not available.
എന്തായാലും നമ്മൾ ഫോർമലായിട്ടൊരു മീറ്റിംഗ്
discuss. Yeah, right. And also just get the details from the other state. What type of formulations they are giving, from what age, like that.
Another question is, how expensive is IGRA testing?
I think that question should not arise. If the patient is eligible for IGRA testing as per government policy, then it should be done free. Free IGRA is available. ആകെയുള്ള പ്രശ്നം എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഓഫൺ IGRA is done for other indication. ഇപ്പം ഒരു ഫോറിൻ കൺട്രിയിൽ യാത്ര ചെയ്യണം, അപ്പൊ അങ്ങനെ വരുമ്പം അതിനുവേണ്ടി IGRA അവർക്ക് ആവശ്യമുണ്ട്. അത് നമ്മളെ പ്രോഗ്രാം അനുസരിച്ച് ചെയ്യേണ്ട ആവശ്യമില്ല. അങ്ങനെയൊക്കെയുള്ള ഇൻഡിക്കേഷൻ വരുമ്പോൾ പേഷ്യന്റ് മേ ഹാവ് ടു ഗോ ടു പ്രൈവറ്റ് സെക്ടർ ആൻഡ് ഡു ഇറ്റ്. അപ്പൊ അതാണ് ഉള്ളത്.
അവൈലബിലിറ്റി ഇഷ്യൂ ആണ് സഞ്ജീവ്. ഇപ്പൊ അവൈലബിൾ അല്ല ആസ് ഓഫ് നൗ. അതൊക്കെയാണ് ഒരു ഇഷ്യൂ. കണ്ടിന്യൂസ്.
Is there any change in TPT regime for pregnant ladies?
No.
Pregnancy risk versus benefit. നമ്മൾ ആ പറഞ്ഞ റിഫാപെൻറ്റിൻ കൊടുക്കാൻ പാടില്ല pregnant women. So then you may, if necessary, risk versus benefit വെച്ച് if you want to give, you can give INH regime, or you might choose to risk versus benefit വെച്ച് you might decide that you keep the lady under observation. So multiple choices are there. You have to discuss with them. It's not like treatment. This is to prevent TB that occurs in the future. It's not that you're immediately treating. So it has to be a discussion including the gynecologist, the treating TB specialist, and the patient. All these decisions are important.
The question is
hello, Dr. Praveen, എന്നെ കേൾക്കാമോ? Am I audible?
Yes, madam. പറയൂ.
ജസ്റ്റ് ഒരു കാര്യം, എന്താ പറയാ, ഈ ഒരു ടോപ്പിക് നമ്മൾ സെലക്ട് ചെയ്തപ്പം ആസ് പെർ അവർ എക്സ്പീരിയൻസ് ആയിരുന്നല്ലോ, ഒരു ചലഞ്ചസ് ഫേസ് ചെയ്തിട്ട്. അപ്പൊ എനിക്ക് തോന്നുന്നത് ഇന്നത്തെ ഈ ഗ്രൂപ്പിൽ ഒരുപാട് സംശയങ്ങൾ ചോദിച്ചുകൊണ്ടിരിക്കുന്നുണ്ട്. അപ്പം അവയർനെസ് ഇല്ലാത്തത് കൊണ്ടോ അതല്ലെങ്കിൽ എന്താന്ന് നമുക്ക് മനസ്സിലായിരുന്നില്ല.
വീണ്ടും ഡിസ്കണക്റ്റഡ് ആയി. അടുത്ത ക്വസ്റ്റ്യനിലോട്ട് പോവാം. വേണുഗോപാൽ സാർ ചോദിച്ചിരിക്കുന്നത്, when TB elimination from India is possible?
We'll hope for the best. Maybe by 30.
ചോദിച്ചുകൊണ്ടിരിക്കുന്നുണ്ട്. അപ്പം അത് മാഡത്തിനോട് പറ്റുമെങ്കിൽ ഒരു സെഷൻ അവർക്ക് എക്സ്പീരിയൻസ് ചെയ്തിട്ട് അവരുടെ ഫീൽഡിലെ ഒരു എക്സ്പീരിയൻസ് വെച്ച് അവർക്ക് ഒരുപാട് കൊറീസ് ഉണ്ടെന്നാണ് മനസ്സിലാവുന്നത് ഇന്നത്തെ ഈ ഒരു ക്വസ്റ്റ്യൻസ് ചാറ്റ് ബോക്സിൽ കാണുമ്പോൾ. അപ്പൊ അതിന് വേറെ സമയം കൊടുത്ത് അല്ലെങ്കിൽ അവർക്ക് ചോദിക്കാനുള്ള അവസരം കൂടി കൊടുക്കാവുന്നതാണെന്നുള്ളൊരു സജഷൻ ഞാൻ പറയുകയാണ്. അതിൽ നമുക്ക് തീരുമാനം എടുക്കാവുന്നതാണ്. ഡോക്ടർ പ്രവീൺ.
യെസ് മാഡം, നമുക്ക് ക്വസ്റ്റ്യൻസ് പെട്ടെന്ന് പറഞ്ഞു പോവാം. ഇപ്പൊ തന്നെ ആൻസർ ചെയ്യാം മാഡം.
Okay.
Is there a possibility of false positivity in CYTB testing in patients with dermatographism or a patient who gives history of skin allergy like insect bite reaction?
So in all these testing, both false positives and false negatives are possible. The false positives generally occur because of cross, reactivity with the other environmental mycobacteria which are present in soil, water, and all that. And നമ്മളെല്ലാവരും exposed are. So we will all have some amount of immunity to these environmental mycobacteria. So as you get the testing more selective, Mando is just a mix of so many antigens. So there will be a lot of cross reaction with Mando and NTM, which is commonly present in the community. ഈ CYTBയും IGRE ആക്കുമ്പോൾ that positivity will reduce, but it is not absolute. So there are so many reasons why people can be positive, so many reasons why it can be false positive and false negative. Both these things are possible.
Any low age cutoff for levofloxacin usage?
No, if that is absolutely indicated for, means the contact is with a multi-drug resistant TB, levofloxacin is indicated. There's no.
Okay, why IGRA is not recommended below 5 years?
No, DIGRA or any test for TPT is not indicated below the age of 5 years because there is a high chance for getting them infected with TB because there's a 50% chance. So it comes under that category of edema prophylaxis. We are preventing the primary prophylaxis.
Due to the probability of the false negative reports, due to their ill development of the cell-mediated immunity or type 4 delayed hypersensitivity reaction. So that may not be well developed in less than 5-year-old and also in HIV patients. So that's why we are not doing the test. Even if we are doing the test, we may get false negative reports, while as the child will be highly prone for TB.
ഈ രണ്ട് കാരണങ്ങളും ഉണ്ട് മാഡം പറഞ്ഞതും അതേപോലെ തന്നെ ഈ പറഞ്ഞ ഒരു poorly developed immune system. Till what age gastric lavage for CBNAT to be used in children? Till what age and upper age?
Upper age ഒന്നുമില്ല. I mean, we
if they
have
can
done for
spit out
adults and
sputum,
we got
yeah, if
positive in adults. So
they can spit out
adults
sputum, then you can do that. You can do the sputum. If they are not able to spit out by any reason, then you can go for a gastric aspirate.
How we follow up extrapulmonary TB cases after treatment? How long? It's not regarding infection.
TBT.
Extrapulmonary, എല്ലാ forms of TB are supposed to be followed up for 2 years as per program guidelines. നടക്കുന്നില്ല, പക്ഷെ that is the guideline.
How often should we check for TB for health workers who are in regular contact with TB patients?
നമ്മൾ ടെസ്റ്റ് ചെയ്യണില്ല. So one of the reasons why our committee in Kerala decided not to go with it is there is continuous exposure. So once so many other countries in the world, എപ്പോഴെങ്കിലും ഒരു TB patient വന്ന് exposure വന്നു കഴിഞ്ഞാൽ you test, and if the health worker is positive, you treat them. They will not get exposed again. Whereas in our country, the assumption is that even if you take 3 months of treatment, from the 4th month onwards, again you will be repeatedly. അപ്പം ഒരിക്കൽ ടെസ്റ്റ് ചെയ്ത് പോസിറ്റീവ് ആയി കഴിഞ്ഞാൽ പിന്നെ എപ്പോഴും ടെസ്റ്റ് ചെയ്താൽ എപ്പോഴും പോസിറ്റീവ് ആയിരിക്കും. So there is no point in repeatedly testing. For study purposes, we have very good studies from CMC Vellore and all, where Dr. DJ Christopher and team from the beginning. So nursing students joining for PSC nursing students joining at the start, they test. So even when they join, certain percentage will be positive, and then at the end of the course, they again test, and they find that so many percentage have got infected while because they studied nursing in the college. അപ്പൊ ആ രീതിയിൽ ചെയ്ത് നോക്കാം for research purpose. അല്ലാതെ എപ്പോഴും ടെസ്റ്റ് ചെയ്യുന്നതിൽ ലോജിക് ഇല്ല.
So next is regarding tuberculin skin test. It's being used for diagnosis of TB for more than 5 decades. So was the doctors wrongly treating children with TB all those years?
I mean, there is no confusion on that. I have been treating TB for the last 30 years as a specialist. I am known as a national expert. I have not done a single Mando for any patient for diagnosing TB. Well, so it can be treated that way. You don't. The point is, if suppose I come to you with a lymph node and you do a IGRA for me, my IGRA or Mando will be positive. I am 100% positive. Similarly, you do for any person coming with a lymph node to you, 20% of Kerala population will be positive. But the proportion of people who have TB in 1 lakh is only around 60 in Kerala. So, whereas if you test with a Mando, 20,000 will be positive in 1 lakh. So, are you going to treat all the 20,000? So, that is the logic.
Why TPT is not given to infant with HIV if there is no contact? For 1 to 5 years, it's given.
Less
0
than
to
1
1
year.
year. 1 to 5.
Yeah, less than 1 year, we are giving only if there is a contact, because already they have HIV, they are on treatment with, they are on ART treatment. So on the top of that, this TPT also, I think the side effects, everything is going to be more. And the chance of them getting TB generally, unless you have a contact, generally means unless they have that much of immunosuppression, is less. So that is why we generally wait.
അടുത്തത് സാർ ആൻസർ ചെയ്തെന്ന് തോന്നുന്നു. Does the skin test become negative after treatment or does it remain positive?
Skin test can become negative because of energy and all that. But generally it will remain positive. ഇങ്ങനെയുള്ളവർക്ക് നമ്മളൊരു ടെസ്റ്റ് ചെയ്ത് ഒന്നുകൂടെ ഒന്ന് resensitize ചെയ്ത് ടെസ്റ്റ് ചെയ്ത് they'll come as positive, even the ones who become negative. It's called the boosting phenomenon.
Yeah, the boosting effect is quite well known even with your Manto PPD. So that cannot be taken as whether the treatment is satisfied or treatment is completed.
മാഡം, ബൂസ്റ്റിംഗ് എഫക്റ്റ് ഇഗ്രയ്ക്കകത്തും CYTV-യിലും റിലേറ്റീവ്ലി വളരെ കുറവാണെന്നാണ് പറയുന്നത്. നോ ബൂസ്റ്റിംഗ് എന്നുള്ള രീതിയിലാണ് പറയുന്നത്.
It is more with the Manto, but it is, you cannot say blanket no. You can have it with.
നോട്ട് ബ്ലാങ്കറ്റ് നോ.
You can have it, but generally less, but it is more with our old Manto test.
ഓവർ എ പീരീഡ് ഇത് നെഗറ്റീവായി പോകും. വെയിൻ ഓഫ് ചെയ്ത് പോകും ഈ ഇഗ്രയും CYTV-യും. ബട്ട് മാൻഡോ ഓൾമോസ്റ്റ് ലൈക്ക് ലൈഫ് ലോങ് പോസിറ്റിവിറ്റി ആണ്. മെജോറിറ്റി ഓഫ് ദി CYTV ആൻഡ് ദി ഇഗ്ര വിൽ ബിക്കം നെഗറ്റീവ് ആഫ്റ്റർ 2 to 3 years.
Okay. Is CYTV available for private hospitals?
ഓൾറെഡി നമ്മൾ പ്രോഗ്രാം ചെയ്യുന്ന അമല അങ്ങനെയുള്ള പല ഹോസ്പിറ്റലിനും ഓൾറെഡി കൊടുത്തു കഴിഞ്ഞു. It's also available for purchase. If your private hospital wants to purchase CYTV, you can get it from Serum Institute of India. But the program will give it to you free. I mean, അതിനുള്ള ലോഡ് കാണണം. എല്ലായിടത്തും കൊണ്ട് സ്റ്റോക്ക് ചെയ്യാനുള്ള സ്റ്റോക്ക് കാണില്ല. But if your hospital has a sufficient load of TB patients and contacts are coming there, children are coming there, then you can actually provide.
We have it. Gokulam Medical College we have, because we have a TB.
അതാ പറഞ്ഞത്, പല പ്രൈവറ്റ് ഇൻസ്റ്റിറ്റ്യൂഷൻ ഓൾറെഡി കൊടുത്തു കഴിഞ്ഞു.
Okay. Next is CBNAT absolutely necessary before TPT?
Only symptom screening കഴിഞ്ഞാൽ അല്ലെങ്കിൽ എക്സ്റേയിൽ എന്തെങ്കിലും ലീഷൻ ഉണ്ടെങ്കിൽ നമ്മൾ CBNAT ചെയ്യണം. അല്ലാതെ ഒരു സിംറ്റവും ചുമയൊന്നും ഇല്ലാത്ത ആളെ ചുമ്മാ തുപ്പൽ വിട്ട് CBNAT ചെയ്യണില്ല.
അത് നമ്മുടെ TB ഡയഗ്നോസിസ് ഫോളോ ആ ഒരു ഫ്ലോ ചാർട്ടിൽ തന്നെ ഉണ്ടല്ലോ. You have an X-ray, the X-ray is abnormal or suggest TB suggestive findings, then only we go for CBNAT.
അല്ല, അതിനകത്ത് എക്സ്റേയുടെ കാര്യം പറഞ്ഞത് ഡോക്ടർ ഷിയാസ് പറഞ്ഞ പോലെ എല്ലാ സ്ഥലത്തും ആ ഒരു മെസ്സേജ് എത്തിയിട്ടില്ല. എനിക്ക് തോന്നുന്ന ഇനിഷ്യലി ഒരു ഡോക്യുമെന്റ് ഞാൻ കണ്ടതായിട്ട് ഓർക്കുന്നു, ചെസ്റ്റ് എക്സ്റേ മേ ബി ടേക്കൺ എന്നുള്ള രീതിയിൽ. അപ്പൊ അതുകൊണ്ടാണെന്ന് തോന്നുന്നു അത് ഈ ഒരു സിംറ്റം
നമ്മള് ഡോക്യുമെന്റ് ഉണ്ടാക്കിയ ലളിത മേഡം ഞാനൊക്കെ എഴുതിയതാണ്. ആ ആദ്യ ഡോക്യുമെന്റ് ഉണ്ടാക്കിയപ്പോൾ തൊട്ടേ ചെസ്റ്റ് എക്സ്റേ ഈസ് എസെൻഷ്യൽ. പ്രാക്ടിക്കലി വി നോ ദാറ്റ് ഹെൽത്ത് സർവീസ് ആയാലും, ഞാൻ ഇടുക്കി D2 ആയിരുന്ന കാലത്ത് ഞാൻ എക്സ്റേ എടുക്കാൻ പേഷ്യന്റ് തമിഴ്നാട് വിടുമായിരുന്നു, കേരളത്തിൽ നിന്ന് എടുക്കാൻ പറ്റാതെ. അപ്പൊ അങ്ങനെയുള്ള സ്ഥലങ്ങൾ കേരളത്തിലുണ്ട്. എക്സ്റേ എടുക്കാൻ പലപ്പോഴും ബുദ്ധിമുട്ടാണ്. അങ്ങനെയാണ് നമ്മൾ കേരളം അപ്രണ്ട് ആയിട്ട് പുഷ് ചെയ്തത്. ബിക്കോസ് അറ്റ് വൺ പോയിന്റ് വി കുഡ് നോട്ട് ആക്ച്വലി take X-rays properly. So that issue is there. But our thinking should be that X-ray എടുത്തില്ലെങ്കിൽ TPT കൊടുക്കാതിരിക്കണമാണ് നല്ലത്. ഒരു ആക്റ്റീവ് TB കയറി നമ്മൾ TPT കൊടുത്തു കഴിഞ്ഞാൽ you will only create havoc in the patient.
How to proceed if TPT is discontinued by self?
Here's പറയണം interruption and treatment.
ഇന്ററപ്ഷൻ ജനറലി അത് ഓരോ റെജിമെനും ഓരോ ഗൈഡ് ലൈൻ ആണ് ഉള്ളത്. പിന്നെ ജനറലി അതിന്റെ ഒരു കംപ്ലീഷൻ ക്രൈറ്റീരിയ ഉണ്ടാവും. 80% ഡ്രഗ്സ്, ഒരു 20 to 30% എക്സ്ട്രാ ടൈം കൊടുത്ത് കംപ്ലീറ്റ് ചെയ്യാൻ പറ്റും. അങ്ങനെ കംപ്ലീറ്റ് ചെയ്യാൻ പറ്റുമെന്നുണ്ടെങ്കിൽ നമ്മൾ വി വിൽ കണ്ടിന്യൂ. അങ്ങനെ കംപ്ലീഷൻ ഇത് കിട്ടാൻ പോസിബിലിറ്റി ഇല്ല എന്ന് കാണുവാണെന്നുണ്ടെങ്കിൽ നമ്മൾ വി വിൽ സ്റ്റോപ്പ് ദ ട്രീറ്റ്മെന്റ്. എന്നിട്ട് വേണമെങ്കിൽ റീസ്റ്റാർട്ട് ചെയ്യാം, either the same regimen or maybe a different regimen.
Next is it mandatory to screen for TB in children before starting ICS in bronchial asthma?
ഇല്ല, it is not.
Smaller dose.
CBNAT from gastric aspirate is always negative and practically difficult, especially for smaller children. Or comment ആണ്.
See, I've heard that comment multiple. പ്രത്യേകിച്ച് ഞങ്ങളുടെ മെഡിയോളോ ടാസ്ക് ഫോഴ്സ് ഒരു മെക്കാനിസം ഉണ്ട്. സോ ഐ എം ദ ചെയർ ഓഫ് ദാറ്റ്. ഇപ്പൊ പല കോളേജിലും പോകുമ്പോൾ ഐ സ്റ്റഡി ദ ഡാറ്റ ആൻഡ് ഗോ. അപ്പൊ വി ഹാവ് പീപ്പിൾ ഡോക്ടേഴ്സ് സ്റ്റാൻഡിങ് അപ്പ് ആൻഡ് സെയിങ് ഞങ്ങൾ കുറെ ഇത് ചെയ്തു പക്ഷെ പോസിറ്റീവ് ആയില്ല. And then we find that among the TB diagnosed in that hospital, 70% were positive on gastric aspirate. അപ്പം അവിടെ തന്നെ then they get surprised. ഞങ്ങൾ ഹോസ്പിറ്റൽ പോസിറ്റീവ് ഞാൻ അറിഞ്ഞില്ല അതെങ്ങനെ വന്നു. But the thing is, when you do it properly, the technique and everything is good. Dr. Virendra Singh സ്ഥിരം പറയാറുണ്ട് that when you do it properly, you do get positive results. So about 70%, 60% positivity. 100% positivity കിട്ടില്ല. 60-70% positivity is always available. അത് ഇന്നത്തെ കാലത്ത് നോട്ട് ജസ്റ്റ് പീഡിയാട്രിക് TB, ഏത് ഫോം ഓഫ് TB ആയാലും, ലിംഫ് നോഡ് TB ആയാലും, എല്ലാ ഫോംസിലും യു ട്രൈ ഫോർ മൈക്രോബയോളജിക്കൽ കൺഫർമേഷൻ. എന്ത് മെഡിക്കൽ ലീഗൽ ഇഷ്യൂസ് എന്ത് വന്നാലും യു ആർ ലുക്കിംഗ് ഫോർ യുവർ പ്രൊട്ടക്ഷൻ. നോക്കിയിട്ട് നെഗറ്റീവ് ആണെങ്കിൽ കുഴപ്പമില്ല, യു ക്യാൻ ഗിവ് ATT, ബട്ട് യു ഹാവ് ടു ലുക്ക് ഫോർ മൈക്രോബയോളജിക്കൽ കൺഫർമേഷൻ.
അതുപോലെ തന്നെ മറ്റൊരു കാര്യം, നമ്മൾ ഇതേപോലെ ഗ്യാസ്ട്രിക് ലാവേജ് ചെയ്യുന്ന കേസ് എത്രയും പെട്ടെന്ന് ടെസ്റ്റ് ചെയ്യണം. നമ്മൾ നേരത്തെ കൂട്ടി ലാബിനെ ഇൻഫോം ചെയ്ത് ഈ സാമ്പിൾ ആദ്യം തന്നെ എടുക്കണം എന്നൊരു ഇത് കൊടുത്തു കഴിഞ്ഞാൽ കുറച്ചും കൂടെ പോസിറ്റിവിറ്റി കിട്ടും. അല്ലെങ്കിൽ ഈ അസിഡിക് മീഡിയത്തിൽ കിടന്ന് തന്നെ കുറേ കേസ്, ഇപ്പോൾ സപ്പോസ് ആഫ്റ്റർ 2 to 3 days ആണ് ചെയ്യുന്നതെന്നുണ്ടെങ്കിൽ ഈവൻ DNA പോലും ഇൻഡിറ്റക്റ്റബിൾ ആയി പോകാം. അന്നേരം എപ്പോഴും നേരത്തെ കൂട്ടി ഇൻഫോം ചെയ്യുക, എസ്പെഷ്യലി ഈ ഗ്യാസ്ട്രിക് ലാവേജ് സാമ്പിൾ, CSF സാമ്പിൾ, അതുപോലെ ലിംഫ് നോഡ് പസ് സാമ്പിളൊക്കെ ആണെന്നുണ്ടെങ്കിൽ.
Okay. Next is whether we can choose between IGRA and CYTB in special situations. In remote tribal population, can we do IGRA instead of CYTB because of difficulty in follow-up? അങ്ങനെ ഒരു ഓപ്ഷൻ കൊടുക്കുമെന്നുള്ള.
Your tribal action plan, state is supposed to prepare something called a tribal action plan. അപ്പൊ നേരത്തെ പറഞ്ഞ പോലെ, if you're going to a tribal area and repeat, one of the disadvantages of doing a skin test, be it Manto or CYTB, is that one, the technique has to be correct. The person who performs the test, reads the test, everything has to be perfect. Patient has to come on 2 different occasions for reading, which is apart, and there is always dropout. അപ്പൊ അങ്ങനെ വന്ന് ഇഫ് യു ആർ ആന്റിസിപ്പേറ്റിംഗ് എ ഡ്രോപ്പ് ഔട്ട്, ട്രൈബൽ ഏരിയയിൽ നമ്മൾ ഒരിക്കൽ പോകണുള്ളൂ, കാട്ടിന്റെ അകത്ത് പോകണു, തിരിച്ചവിടെ പോകില്ല, അല്ലെങ്കിൽ അവർ കാട്ടിന്റെ അകത്ത് പോകും, റീഡിംഗ് പറ്റില്ല എന്നുണ്ടെങ്കിൽ ഇറ്റ് മൈറ്റ് ബി എ സൗണ്ട് ഐഡിയ ടു ടേക്ക് ഇഗ്ര. അതിൽ തെറ്റൊന്നുമില്ല, അവൈലബിൾ ആയിരിക്കണം. ഇഗ്രയുടെ ഡിസഡ്വാൻറ്റേജ് എന്ന് പറഞ്ഞാൽ സാമ്പിള് പെട്ടെന്ന് പ്രോസസ് ചെയ്യണം. ഇപ്പൊ ഈ പറഞ്ഞ ട്രൈബൽ ഏരിയ കാട്ടിന്റെ അകത്ത് പോയിട്ട് ബ്ലഡ് ഡ്രോ ചെയ്ത് വന്ന് അത് പ്രോപ്പർ ആയിട്ട് സെൻട്രിഫ്യൂജ് ചെയ്യാനൊന്നും ഉടനെ പറ്റിയില്ല എന്നുണ്ടെങ്കിൽ ദാറ്റ് വിൽ ബിക്കം ഫാൾസ് നെഗറ്റീവ്. അപ്പം അതുകൊണ്ട് 2 വശവും നോക്കിയിട്ടാ ചെയ്യാം.
Okay. Next is can TPT be given to a lactating mother?
കൊടുക്കാമല്ലോ ഷിയാസെ.
It can be given because we are giving it to newborns. So what is that? Even newborns we give TPT.
ഇല്ല മാഡം.
So
കോൺട്രാൻഡിക്കേഷൻ ഇല്ല
MDR
മാഡം.
റെജീംസിലൊക്കെ മാഡം ഈ കുട്ടികൾ കൊടുക്കാൻ പറ്റാത്ത ഡ്രഗ്സ് ഉള്ളപ്പം ബ്രസ്റ്റ് ഫീഡിങ് അലൗഡ് അല്ല MDR റെജീംസില്. അപ്പം ഇതിൽ കോൺട്രാൻഡിക്കേഷൻ ഇല്ല എന്നാ ഇപ്പം അർഷദ് പറഞ്ഞു.
Is TB preventive therapy to be repeated for a second contact with a case of pulmonary TB after being given once?
It's a controversial area. Again, programmatic decision. അത് എങ്ങനെയാ ആരെങ്കിലും പറയണം അർഷദോ? Generally, you give TPT once in a lifetime of a person. പിന്നെ കൊടുക്കണ്ടെന്നൊരു ഫിലോസഫി
but
ഉണ്ട്.
we are giving it in
But in theory,
with HIV,
reinfection വരുമ്പോഴും റിസ്ക് കൂടുതലാണ്. അപ്പൊ in theoretically, you could actually give also. അതൊരു പ്രോഗ്രാമാറ്റിക് ഡിസിഷൻ ആണ്.
Sanjeev, we are giving it in for people living with HIV.
HIV നമ്മൾ ട്രീറ്റ്മെന്റ് കഴിഞ്ഞാലും കുറെ കാലം WHO ഗൈഡ്ലൈൻ 3 വർഷം കൊടുക്കണം എന്നാണ്. ട്രീറ്റ്മെന്റ് കഴിഞ്ഞിട്ട് 3 വർഷം കൊടുക്കണം.
So there may not be any harm in repeating. That's what I say. Extrapolate.
ടെക്നിക്കലി റീഇൻഫെക്ഷൻ വരുമ്പോൾ പിന്നെയും വരാൻ അഡ്വാൻറ്റേജ് ഉണ്ടാവും.
ഡോക്ടർ സഞ്ജീവ്, കറന്റ് ആസ് പെർ ഗൈഡ് ലൈൻസ് വൺസ് ഇൻ എ ലൈഫ് ടൈം എന്നുള്ളതല്ലേ
അങ്ങനെയാണ് പറയുന്നത്. പ്രോഗ്രാമാറ്റിക് ഡിസിഷൻ ആയിരിക്കണം. വാക്സിനേഷൻ ആർക്ക് കൊടുക്കണം ആർക്ക്.
Okay. What all things to be monitored during clinical follow-up in a child contact of MDR on 6-month levofloxacin?
Madam?
I think Generally, the first and foremost is, I think we have to look for the development signs of an active TB. That is TB infection processing into, and then sort of any allergy. And the levofloxacin, the fluoroquinolones, in general, we say the damage to the growing cartilage and all, but it has not been proved. I think these are all the ones which I can think of. Hepatotoxicity also, but not like the rifampicin regime.
Specifically, tendinitis and some neurological manifestations are said to be more common in levofloxacin, like
That's
seizure.
what fluoroquinolones in general, they damage the growing cartilage and all. But I think we are not seeing much all said and done. That has.
അടുത്തത് INH-ന്റെ അപ്പർ limit. Dose of INH in TPT with 3HR for 40 kilogram child, 300 milligram or more can be given.
So 3HR, the maximum limit is 300. 3HR regime. I don't know the rifampicin 3HP.
Rifampicin കൂടുതലാണ് കൊടുക്കുന്നത് വീക്ക്ലി
900 വരെ
900 മില്ലിഗ്രാം
900 വരെ
ആഴ്ചയിൽ.
മറ്റേത് 300 ആണ് അപ്പോൾ ലിമിറ്റ്.
While on TPT, if signs of active disease develop, how to proceed?
Then you have to stop the TPT, do rule out drug resistance and start appropriate regime.
So these are the questions on chat box. If anyone else have any queries, can unmute and ask. Arshad sir, എന്തെങ്കിലും കമന്റ്സ് പറയാനുണ്ടോ?
ഒന്നുമില്ല ഡോക്ടർ പ്രവീൺ, നല്ല എക്സ്റ്റൻസീവ് ആയിട്ടുള്ള ഒരു ഇതായിരുന്നു, വേറെ ഡൗട്ട്സ് ഒന്നുമില്ല.
സാറിന്റെ കമന്റ്സ്
ഡൗട്ട്സ് അല്ല, കമന്റ്സ് റിഗാർഡിംഗ് ദ സിസ്റ്റം ഇംപ്ലിമെന്റേഷൻ ആൻഡ് ദ പ്രോബ്ലംസ് ഓർ ദ ചാലഞ്ചസ് യു ഫേസ്.
അല്ല, അതിപ്പോ നമുക്കൊരു പുതിയ ഇൻഫർമേഷൻ ഡോക്ടർ ദീന നായരുടെ ഇൻഫർമേഷൻ നമുക്ക് തന്നെ ഡോക്ടർ സഞ്ജീവിനൊക്കെ ഫോളോ അപ്പ് ചെയ്തൊന്ന് കുറച്ചുകൂടെ ഫാസ്റ്റർ ആക്കാൻ പറ്റുമെങ്കിൽ TB ഫോർ ചിൽഡ്രൻ അത് ഒരു നോട്ട് ചെയ്ത് ആദ്യമായിട്ടാണ് ഈ നമ്മുടെ ഈ VC-യിലാണ് ഇത് അറിഞ്ഞത് എന്നുള്ള ഒരു ഇൻഫർമേഷൻ. അത്രേ ഉള്ളൂ, വേറെ ഒന്നുമില്ല.
എനിക്ക് തോന്നുന്നു എന്റെ സൈഡിൽ നിന്ന് ഒരു കമന്റ് എന്ന് പറഞ്ഞ രണ്ട് കാര്യങ്ങളാണ്. ഒന്ന്, ഡോക്ടർ അർഷദ്, നമ്മൾ കുറച്ചു കാലമായിട്ട് പ്ലാൻ ചെയ്യണു. ഗവൺമെന്റ് ഓഫ് ഇന്ത്യ WHO ലെവലിൽ നമ്മൾക്ക് റിക്വസ്റ്റ് വന്നതാ ഈ നമ്മളുടെ ഈ റെജീംസിന്റെ ഇതുവരെയുള്ള എഫിക്കസി, ബാക്കിയുള്ള എഫിക്കസി അല്ല, കൊഹോട്ട് ബാക്കിയെല്ലാം ഒന്ന് ഡോക്യുമെന്റ് ചെയ്യാന്ന്. അപ്പൊ നമ്മളെ ഡിസ്ട്രിക്ട് TB സെന്റേഴ്സിലുള്ള എല്ലാവരും ഒരു ടീമും TB LTBI കമ്മിറ്റി മെമ്പേഴ്സ് എല്ലാവരും കൂടെ ചേർന്ന് we get together and the idea was to write a protocol. Probably I'll take the lead now and we'll write a protocol and do that. Why that is needed is, നേരത്തെ ഷിയാസ് പറഞ്ഞു, if we are moving to INH rifampicin in children, നമ്മൾ കുറെ കാലം INH rifampicin കൊടുത്തു. That was also something that the program wanted us to demonstrate. നമ്മൾ ചെയ്തില്ല. But they wanted us to demonstrate by documenting this and publishing it so that they could replicate in other parts of India. അപ്പൊ നമ്മളെ സക്സസ് വേറെ സ്ഥലത്ത് കൊണ്ടുപോകാനായിരുന്നു പ്ലാൻ. പക്ഷെ ഇപ്പൊ നമ്മൾ ബാക്കിയുള്ളവർ ചെയ്യണ പോലെ തിരിച്ച് ഞങ്ങൾ ചെയ്യാതെ പോകണമെന്ന് പറഞ്ഞാൽ we are actually taking a step backwards from what we were. That is one thing. The second thing is to Lalitha madam ഇടയ്ക്ക് നേരത്തെ ഒരു ഡിസ്കഷൻ ഉണ്ടായിരുന്നു that particularly in the northern districts of Kerala, in between there was some resistance to, I don't know what is the current scenario. I'm talking from information about 6 months to 1. You were also there at that meeting. So there are, child being tested, 6-year-old child coming as IGRA positive. And then the treating doctor says that, illa TB onnu illa marunnu venda. Angane parayarundi. So IAP was planning that they will do a retraining of all. Oru kalathu IAP 2000, that period, I think you did a lot of trainings and that was an excellent exercise. So Kerala did very well in that respect. So maybe it's time for IAP to restart or redo all those trainings, refresher training. നേരത്തെ STO പറഞ്ഞ പോലെ, a lot of doubts which indicates that maybe there is a need for retraining.
Okay, I think Praveen can take up that. He is also an IAP official as well.
Yeah, we will discuss with the state president and we will take it up, sir. So, Sakina,
The dose of 3HR, somebody had asked. So INH is less than 10 year, 10 milligram per kilogram, and rifampicin 15 milligram per kilogram. But if it is more than 10-year-old, INH is 5 milligram and rifampicin is 10 milligram. So, but FDC is available as she has mentioned.
Madam, Sakina Madam, log out ചെയ്യാൻ തോന്നുന്നു. So if there are no more doubts, I think we can wind up the session. So I thank both the speakers. Both are, as we know, state level and national level experts in TB. So we are very fortunate to have these experts today with us. So thank you, Sanjeev sir, as well as Lalitha Madam. So thank you all the participants for the active participation and discussion regarding the TB. So we will conduct further sessions on this topic. As Madam said, there are still many doubts regarding this. So thank you and good night. വേറെ ഏതെങ്കിലും കമന്റ് ഉണ്ടെങ്കിൽ പറയാം, അല്ലെങ്കിൽ നമുക്ക് നിർത്താം.
Thank you. Good night.
Thank you. Good night.
Good night. Bye bye.